Okay, so let's look at four separate clinical situations that you might encounter. The first one is, what do you do when asked to treat a pseudoaneurysm measuring between 1 and 2 centimeters in size? And the index case that I'm showing is the cine clip that you see below. So what would you do if you were asked to treat this? And the potential responses are recommend serial follow-up, waiting for thrombosis to occur spontaneously, recommend ultrasound-guided compression, recommend ultrasound-guided thrombin injection, recommend angiography-directed treatment, or recommend surgery. Well, I can tell you that what I elected to do was to inject it with thrombin. I injected 0.05 cc's, which translated into a dose of 50 units of thrombin, and this is the result. So you can see that the pseudoaneurysm thrombosed, but in addition, a little bit of thrombin leaked out and produced this intraluminal thrombin plug that was attached to the neck of the pseudoaneurysm. This was fairly disconcerting to me when I saw it. I immediately checked the patient's pulses. Then I checked my pulse, and everybody was doing okay. I was a little tachycardic, but the patient was fine. And he never developed any clinical symptoms. He never lost pulses. He never developed any signs of ischemia. This is a series of scans that were done in follow-up of this patient, and you can see on the immediate post-thrombin injection to the left, the little thrombin plug in the lumen of the artery. The next day, we rescanned him, and it was still there. We were relieved that it hadn't migrated distally. It had gotten a little bit smaller. And then by day 20, it had completely resolved, and this patient did fine, never had any problems whatsoever. Now, subsequently, I've seen this 2 other times, and each time I've seen it, I've been very worried about the patient, but each time the patient has done fine and never had any problems, never required any therapy. But this does bring us into a discussion about contraindications to thrombin injection of pseudoaneurysms. And there's several that have been discussed in the literature. One is a short neck. And the patient that I showed you certainly falls into that category. Now, unfortunately, the articles that have been written and have listed a short neck as a contraindication never defined what a short neck is. How short is too short to inject? So that's fairly nebulous. However, in series of patients that have been reported in whom thrombin has been injected successfully without complications, the ranges of neck size or neck lengths that have been reported range all the way from 0 to 31 millimeters. So clearly you can inject necks that are very short without problems and do that without too much difficulty. Now, another contraindication is a wide neck. Now again, how wide is too wide has not been defined in the literature. But when reported in series of patients that have been thrombosed successfully without complications, the width of the neck has ranged from 0.3 millimeters to 8 millimeters. Problem is, none of these studies describe exactly how they measured the width of the neck. They don't say if they measured the maximum width or the minimum width. They don't say whether they measured it during systole, when it's larger, or during diastole, when it's smaller. And then they also don't say whether they measure it with color or with grayscale. And clearly the neck size is going to look bigger with color than it is with grayscale. So although wide necks are a relative contraindication, there really is very little guidance as to how wide is too wide. Now, another contraindication that seems fairly straightforward is poor visualization of either the needle or of the pseudoaneurysm itself. If you don't know exactly where the needle tip is, you should not be injecting. And then finally, contraindication is that rare patient that has a combined pseudoaneurysm and arteriovenous fistula. When there's a combined PSA and fistula, then there's the potential that the thrombin that you inject will leak out of the venous drainage, go right into the venous system, and cause either DVT or worse, travel up to the lungs and cause a PE. So these are some of the contraindications to thrombin injection. Another factor that plays into your decision whether to inject or to treat pseudoaneurysms is the natural history of untreated pseudoaneurysms. And actually the natural history is pretty good. This is a very nice study that came out in the late 1990s that followed a series of small pseudoaneurysms. And they defined small as pseudoaneurysms that were less than 3 centimeters in size. And pseudoaneurysms in that size range thrombosed spontaneously at a rate of 88%, 72 out of 88. And the range of time that it took to thrombose ranged from 1 to 125 days, with an average thrombosis time of 23 days. So it may take a while for them to thrombose, but a large percentage of them will thrombose if you give them enough time. Now, this study did discover that spontaneous thrombosis, although it occurs, it's less likely if the patient's anticoagulated or if the pseudoaneurysm is chronic and has developed a fibrous wall. So the conclusion is that you can follow small pseudoaneurysms and treat them only if they persist or if they enlarge. And here's a nice example of a small pseudoaneurysm that we followed over time. You can see in that upper left-hand image, that was when the patient first presented on 3/28. On 4/7, we repeated a scan, and it was still there, hadn't changed much. We repeated a scan 2 weeks after that on 4/21. Pseudoaneurysm was still there. You can see it's partially thrombosed, but still present. And it wasn't until 4/28, 4 weeks later, that the pseudoaneurysm was completely thrombosed. So it took a little while for it to thrombose, but it did. Here's a patient that we diagnosed a pseudoaneurysm one evening. It was late in the day, and we decided we would wait until the next morning to thrombose this pseudoaneurysm. And you can see when the patient came back to have his thrombin injection the next morning, it had already thrombosed spontaneously. Here's another example of a pseudoaneurysm. This is in a patient that had just had a cardiac catheterization. You can see that the pseudoaneurysm has a nice long neck here and has a relatively small, discrete lumen. Well, this patient also had another interesting finding. So the image to the left shows the typical to and fro pattern of flow in the neck of the pseudoaneurysm, but the image to the right was obtained just slightly distal to the neck of the pseudoaneurysm, down near the bifurcation of the femoral artery. And you can see that the flow in this area is very high velocity and very low resistance. This is typical pattern of a associated arteriovenous fistula. And for this reason, plus the fact that the pseudoaneurysm was relatively small, the person who did this case decided not to inject the pseudoaneurysm and just wait for spontaneous thrombosis. Well, the patient was discharged, went home. When he got up out of bed at night to use the restroom, the pseudoaneurysm ruptured. He developed a lot of pain, a lot of swelling at the site. He came back into the emergency room and had a CT arteriogram done. The two images up above, you can see the infiltrating hemorrhage in the groin, as well as the pseudoaneurysm lumen. And in fact, there was a second lumen of the pseudoaneurysm that had developed after it had ruptured. This coronal reconstruction, you can see the two pseudoaneurysm lumens and the hemorrhage surrounding it. And here on the 3D reconstruction, you can see both components of the pseudoaneurysm, here and here. You can also see the early draining vein indicating the presence of an arteriovenous fistula. So let's just review the anatomy on this patient. He had a pseudoaneurysm with a long, slender neck and a classic to and fro pattern arising from the neck. And distal to this, he had an arteriovenous fistula with the classic low resistance, high velocity flow at the site of the fistula. So this represents a coexistent pseudoaneurysm and AV fistula. It really does not represent a combined pseudoaneurysm and AV fistula. And the distinction is important. So, having sorted all that out and having known that this patient had already ruptured once, we decided to thrombose him the next morning, and in fact were successful using 100 units of thrombin.